translating, but because after all, I'm creative. And to be a pen, the me back about it showed ya on the descriptive on your word in Ankasa. It's yeah. Try there. Yeah, but similar approach. What shall we say? Yes, I'm just there. Wow, hey, now we're paying for the one for childhood experiences. Now, it's until then in the breed. In the breed, yeah. Time we are now from online. The na ya kai kunkunchima. Na ya kai kunkunchima. Isuta. Whenever it rains, you find pools and tadpoles lay eggs there. Then frogs lay eggs there, frogs and toads, and then you find their offspring, the tadpoles. Kunkunchima. Oh no, would and then they will fall off. Another mfraba. Children grow, adolescents grow. And up to a point, they stop growing. Why don't they continue growing? The body has mechanisms to truncate the growth. Most small boy hen, Oma, a cocoa, of a tadpole, old baby, till no otto. Nimpan, old baby, Orina, Ninin, Ojay. Damara so yeti with me. You know time behind the team ofu. But ofu abisu bubu. So uti abone be aba. Damana nzama awo yemun. Like the lining of the mouth. The wish we numa as I covered. And now so that the mouth has not covered wind. Body surfaces na ibi wo ho. Then, most men will win no more. Or continue down the throat, baby, Ejenan Oban. Yeah, one could say, baby, I shan't far, Nadina, or such surfaces. Now, there is a balance between growth. Now, from the death of lining. So, into Oma, people were creating there. Time be a nzama constant. In the year, they created a nzama constant. Into nzama bi oha, ever the oha in numusa chaya. The better day is common. Ama and musu a top up. That them constancy why maintained. So, that means them cells here online your body. Dama ibi kwa ne biba. At a rate or a balanced. It's a problem. Yeah. Now, about cancer now. In Zama or halt growth. The mechanisms are also halt growth now. Balance na bad. Nobody baby now I say. So there's a balance between growth and cell death. We call it mucosa, in the linings of the body cavity. So as long as there's a balance, there's no change which we can observe in the body cavities, in the spaces. But when this balance is offset, right? So you can imagine that when there's more cell death than cells are produced, there will be shrinkage. The corollary is that when there's more growth than cell death, then that is the problem of cancer. So when the mechanisms that ensure that we have control, but I can be interrupted at any time, right? Then there's a problem. So that is what cancer is. Apart from that, the cancer has the capacity to invade the structures that are around it. And then also the cells, by the way, a cell is the unit of structure of the body. So I don't know how to explain it to you now. But it's the building blocks of the body, right? So cancer has the capacity to invade structures around it and also to travel from where it started to other places. So these two are cardinal features of cancer. We may have other groups. Let's say a wart. A wart. You see, nothing happens to it. It can stay for several years. Or you may have, let's say, a birthmark. It can stay for several years. Nothing happens to it. There can be several growths. Let's say a keloid. Nothing happens to it. So those growths are called, we term them benign. They are not cancerous. So I hope I have explained what cancer is now. So cancer has the capacity to invade structures around it and also to travel from where it started to other places. Next slide. Right. Whenever I'm asked to talk about the audience, as a church audience, I like making references to the Bible. So I have to be careful because there are very senior Bible people here. I try to look for references in the Bible that speak about cancer. And I found this. You see, so this one, I think they were talking about profanity and some other things, plus gossip. And he said it spreads like cancer. So this is supporting my earlier explanation regarding the behavior of cancer. You see, it says, and their message will spread like cancer. So cancer spreads. Cancer spreads. There is no subject in the world that you can't find in the Bible. Next slide. Right, so I've explained this already. You have normal cells, and the body has mechanisms for healing. So when you have a cut, it heals. And the healing is not extended beyond a certain period. Or the cells stop dividing to close the gap at some point. You see? So we have such mechanisms at the cellular level. But then when there's a problem with the cells in respect of repair, if the cell is unable to repair damage, then that damage persists and it manifests as cancer. So earlier on, I explained the lining of the surfaces of, let's say, the mouth or skin or whatever. So at the microscopic level, say in your microscope, the pathologists will look at the cells of the body with a microscope. And the depiction is what you find on our right side. So we have those cells that have accumulated. Okay. And beneath it is like a partition. So the partition is showing the surface, and then beneath the lower part of the block is the rest of the body. So when we talk about cancer, those cells that appear with different shapes are able to go beyond the barrier. So that is what the pathologist will have a look and say it is cancer. This explanation, I think, is important because not every body mass is cancer. You can have a lesion in the breast. It may not be cancer. A baby botum abada enufunu. Be annoying cancer. You may even have an abscess. It's not cancer. So sometimes people say, oh, I did this and that, it was cancer, I've been healed and so on. No. Once you haven't subjected it to pathological examination and you have proved that it's cancer, you cannot say that you have a diagnosis of cancer. So now we know what cancer is. So local spread. Next slide, please. This is a cross-section. This is a cross-section of the pelvis. Because pelvis, I'm a patch. Yes, sisu no kofum. Now, yeah, a section of it, cross section. So at the cross section, at this level, now the other one also, oh yeah, this section. But Isha, you can see that at one level you have the cervix there. The cervix is the mouth of the womb, and you have the womb. Okay, so when you have cancer, like cancer of the cervix, it can spread. When I talk about local spread, that is what I mean. It can spread backwards and get attached to where usually you would have feces, a rectum. It can spread and get attached to the bladder. It can spread, it can spread in several ways. So that's one key feature. Next slide. Just to demonstrate what we mean by the spread. So the yellow coloration represents nodules. This is the lung. The lung. The yellow coloration represents nodules. So if you do, let's say, a post-mortem in a person who has cancer that has spread to the lungs, you would have something like that. So you see that the nodules, which we call metastasis, the cancer that has spread to that area, is consuming the whole organ. It's virtually consuming the whole organ. It's virtually consuming the lung. So how will you breathe? It will affect you. You can't breathe. So this is an example of what we mean by the spread. This is a cross-section of the brain, and we can see a nodule. A nodule represents cancer that has spread from where it started to the brain. And then there's similar picture. Over time, it will consume the brain. So it means that the function of the brain will be overtaken. So this is what we mean by what cancer is. Now, what are the common cancers? What are the common cancers worldwide? So let's use the color code. I hope you can see it. So prostate is this green one. I don't have a pointer, but I'm sure you can see that most of it is green. So for most parts of the world, prostate is the commonest cancer. There are only a few places, like the Asia. That is where you have a lot of lung cancer. And in some parts of Africa, cervical cancer is number one, not breast. So in those areas, breast is usually number two. And then in most parts of the world, including us, is prostate cancer. So in females too, breast is number one. Right. You use the color code. We use the color code. Then amongst females, breast is number one. See that breast is dominating everywhere, except for some few places where cervical cancer is commonest. So put together, prostate, cervical cancer, and breast together will constitute about 75% of cancers that we see. What are the causes of death worldwide? The causes of death worldwide vary depending upon where you come from. So in the very developed world, and in fact in most places, cardiovascular disease, stroke, heart failure, that's the number one cause of death. Then followed by cancer. Then infectious diseases, malaria, diarrhea diseases, and so on. But the spectrum of diseases vary depending upon where you are located. So for us, we are dominated by infectious disease. Our part of the world is mostly infectious diseases that kill us. But that is changing over time. So in the developed world, cancer may be number two. The very developed world, cancer is number one. We have infectious disease. It is changing over time. So let's look at the percentages. We divide diseases, we partition diseases into communicable disease a non-communicable disease. Communicable disease, I mean disease that can be transmitted from one person to the other, another, through an infectious agent. Okay. Versus non-communicable disease, like cancer, diabetes, they are non-communicable disease. So the spectrum of diseases in Ghana is changing rapidly. Non-communicable disease is taking over. Whereas in the past, it was infectious disease. Now, infectious disease is going down. Okay. So, for our part of the world, in Ghana, cancers constitute 5%. 5% the causes of death. Number one of the non-communicable disease is cardiovascular disease. There's a relationship between them, but it's a bit complex for me to demonstrate now. So I've explained this already. That is breast. Then we have liver. Liver is the next one, followed by cervical cancer and prostate cancer. Well, today we are not talking liver. As at now, there isn't much you can do about liver cancer, right? So we don't usually talk about it. But we expect that liver, as most of our liver cancers comes from previous infection with a virus. So now our immunization panel, childhood immunization panel, they include immunization against the virus. So we expect that in 10, 15, 20 years, our incidence of liver cancer will be going down. Next. This is the predicted trend of the incidence of cancer worldwide, obviously because of increase in population, the first one. Because of increases in population over time, you would have more cancers in terms of numbers. But if you take a closer look at the slide, you would observe that for less developed countries like Ghana, the rate of increase, which we refer to as gradient, is sharper than more developed countries. So there's going to be increase worldwide, but the rate of increase of the incidence of cancer is higher in our part of the world than in the developed world. This is because it is related to age. Our life expectancy is increasing. If you can see the slide very well, from 2010 to 2020, in fact, it's still increasing. Our life expectancy, who can tell me the top one? Is it male or female? Female, yes. Female live longer than male. What is the reason? We don't know. Some people say men are biologically weak. Because even amongst babies, the boys die more than men. Yes. Amongst babies, boys die more than girls. Right. Some others, it's not part of the talk. Some others say that we engage in lifestyles that kill us, like smoking and other things that kill us. Anyway, we don't know. But life expectancy is increasing over time. So from 2020 to from 2010 to 2020, we can see that it has changed from about 60 to about 60. Indeed, around 2000, our life expectancy was about 57. But now it's getting to 70. So we have an aging. So that is one of the reasons why I started the talk by congratulating Vivian for setting up this foundation. It's very important. We have an aging population. Many people are living longer than before, which means that we should design programs to satisfy the change in our demography. It is very important. We should not neglect our demography. Worldwide, this is what we observe. In some places, the incidence of cancer has plateaued. Other places is increasing, others is decreasing. In the very developed world, incidence of cancer has started going down. Even though they are aging, they continue to age, but then the incidence of cancer is going down. What did they do to arrive at that? In the US, for instance, you can see the graphs beneath. You see that it's dropping sharply. The green one, it's dropping. This is followed by Europe. That is also dropping. We're talking about the one beneath, in the lower part. On the left, yes, on the left side. Yes. Compared to the ones at the very lower part, is increasing. You see, so our part in the develop, even though in terms of numbers, magnitude, our numbers are low, right? But if you talk about the rate, for them, it's declining, and for us, it's increasing. What did they do? We can't reinvent the wheel. We should learn from what others have done. And that is the basis for our talk. So we were talking about, so far we've been talking about, we call it a subject we call epidemiology, right? So we've been talking about the nature of the cancer, the extent, and the characteristics and so on. But we can't talk about that and leave the main subject of cancer control. So for whilst it is decreasing, we find out what did they do. Okay, what did they do? So some cancers can be prevented, others cannot be prevented, and can be managed or treated, and yet a certain proportion has very bad prognosis. I mean, the outcomes are poor even with management. So let's look at what they have done. So we call this the cancer control continuum. You try to prevent those that you cannot prevent. You screen. I'll explain what we mean by screening. If you screen and you can't get them, you try to diagnose them early, and then you treat. Next. So how can we prevent cancer? We prevent cancer by first identifying risk factors. Risk factors. What is a risk factor? A risk factor is any engagement, lifestyle, genetic constitution, behaviors that puts you at risk of developing a condition. For instance, we know that smoking, or I should use an example outside of cancer. Let's say a child is delinquent, does not go to school. You can predict what is going to happen to the child as an adult because they won't have any profession. So delinquency is a risk factor, right, for a problem adult. So we know that there are some behaviors that predispose you to cancer. So if we are able to identify those behaviors, those lifestyle, and deal with them, and theoretically we think that we can prevent the cancer. Now, these risk factors are partitioned into two. We have modifiable risk factors and risk factors that are not modifiable. Because if you couldn't modify any of the risk factors, then we shouldn't be talking about it. But there are some risk factors. The simplest example that I can give is that women cannot develop prostate cancer. Can women develop prostate cancer? Men would not. Some men, 1% of men, 1% of all cancers, male breast cancer is 1%. But which means as a man, the probability of having breast cancer is very slim, isn't it? Okay. So, but you cannot change your sex. But I have to be careful. These days, people are. Sometimes you receive emails from UK and US, then they will ask you that, how do you refer to yourself? Are you a him, her, or they, or all kinds of. But I remember watching a Discovery Channel, ID, so crime. There's this guy, was they were men engaging with men, and the partner killed the wife. You see, this man was married and yet had a male relationship, killed the wife, and the police were able to identify who killed the wife. So this guy was imprisoned, and after about court cases can take a while. So it was about 6 months to a year after the crime. And then in court, the so-called husband appeared, and the partner who committed the crime also appeared in court. And this guy was wearing a beard, had changed because in prison he had no access to those injections. You see, he had no access to those hormones that made him female. So it means what God has created, you cannot change. You see, so those factors are not modifiable. You can't change your age, you can't change your sex. Those two are the factors that you cannot change. And then the modifiable risk factors we will discuss shortly as we go along. So you should know the risk factors. These are some of the risk factors. So smoking, body weight, alcohol, the sun, even being in the sun alone. But this one, let me pass a comment. Like skin cancers, it's very common in Europe. So we have the melanin. Okay. So if Europeans live in our part of the world, then they also develop skin cancers because they were not made to live here. Like Australia, New Zealand, South Africa, they have skin cancer is very common because the whites there don't have. Okay, risk factor: alcohol consumption, smoking, weight, processed meat, and then some infections. Infections can cause cancer of the stomach, the liver, cervical cancer, and so on. But let's be a little bit more detailed. That's some of the cancers. So let's take cervical cancer, for instance. 100% it can be prevented. 100% cervical cancer can be prevented. Lung cancer, 90% can be prevented. You see, because if you take 100 patients that have lung cancer, okay, a large proportion will have a smoking history. But let me explain. Of all those who smoke, only 15% will develop lung cancer. Okay. But if you take lung cancer patients, 85% are smokers. So it means that 90% of the time it is preventable. Okay. Through a modifiable risk factor. But something like cervical cancer is preventable in total. Then prostate cancer, 0%. It cannot be prevented. Prostate cancer cannot be prevented. Breast cancer, 70% of the time, it cannot be prevented. It's only about 25% of cases that can be prevented. Which means I often encounter patients, you see, we are human, so we always try to link some lifestyle behavior to diagnosis. A lot of the time you cannot. So what is telling us is that for breast cancer, 75% of the time, you cannot link it. It is not because of what this person did or died that is developed the cancer. Okay. Even the sick child, the Jews were wondering have the parents committed a crime. That is why it is manifesting as that disease. You see, and you know what Jesus told them. It is not always that you can link it. So it means prostate, you can't say that it's because the person smoked. Even though there's some relationship, it's not 100%. So you can see there are all kinds of cancers. But you see, we are talking about cervix, prostate, and breast. That is why I've cited those examples. So cervix, 100% can be prevented. Prostate, we cannot prevent it through your risk factors. Breast, only 25% of the time. That's when it can be prevented. Next slide. I'm not too sure whether you can see, but you see on this side, the highest, the bar chart, the highest one, this is smoking. The highest one is China. So the whole world, China has the most people who smoke. So it is not too surprising that if you look at the atlas that we saw previously, you see that the color, sorry. I'm assuming that, I've forgotten that I cannot project. But we looked at the atlas. We looked at the world atlas that depicts geographical areas. And it demonstrated that there's more lung cancer in Asia. It's because they smoke more than any part of the world. This is interesting because, you see, in our part, Europe and the developed world, the number of people who smoke is declining. In our part of the world, it's increasing. So something that we need to look at. So we have now recognized that not all cancers can be prevented through lifestyle. But then there are mechanisms to detect them early. Right? If you cannot prevent them, you can detect them early. So we have what we call screening. So screening is, the definition is tests performed in asymptomatic individuals. So tests performed in people who are not sick in order to detect the presence of disease. So there can be disease in the individual, but that individual may not be sick. Right? You may be harboring disease, but you'll be fine. That is how cancer behaves. You may be harboring the disease, you may be asymptomatic, but then the disease will be there. So when you do tests in such individuals, we call it screening. I always tell people that, look, this GPS addresses that the government is encouraging, and the country should swallow it. Unfortunately, most of us don't. If I go around and ask you what is your GPS address, you will not know. Mine is GE 0669163. That's why in the UK, because people are known. At 40 years, you may receive a script in your mail that go for screening. Go for screening go for mammogram, go for cervical cancer screening. Because they have data, they can locate you. And they have a system. Once you touch that age, they have a population-based screening. So you are invited to do that. If somebody is staying in a hut near the mango seller, have the system detect that person and invite them for screening. It's important that we should be able to locate where we live. And we should have our ages. That is why it is important to have that card. Now we are not utilizing it for that, you see. But I think that once that we have established data, we should move to the next stage of using what we have. It can have several uses. So we screen. We screen. The reason is that something like cervical cancer, it has been shown that it is caused by a virus. Okay. Before it was shown, we used all kinds of indirect means. We say, risk factor is more common in prostitutes, it's more common people who are promiscuous, it's more common people who have several sexual partners. It's only because if you engage in that lifestyle, the chances that you develop the infection is high. But the real cause is the virus. Okay. So once you can prevent the virus or you can prevent the infection, you won't have the cancer. Which means even condom use It's important. But as we speak now, okay, there's a history to it. Now, what we are promoting now is immunization. Like there's six childhood killer diseases that we've used to reduce mortality, infant mortality. Now and under five mortality. Now we have a vaccine for cervical cancer. Okay. So if the virus has engaged already, there's no point to immunize. Okay. So in children, so from 9, let's say 9, 10, 11, 12, who have not engaged in any sexual activity will not have that infection. So when they are immunized, cervical cancer can be prevented. Okay. So immunization can prevent, in fact, now, like, the UN has all kinds of goals. One of the goals is to eliminate cervical cancer because now they have the means to do that, immunization. But unfortunately, it is not part of our immunization panel yet in Ghana. They say that we can't afford it. Yeah. So we can prevent cervical cancer. But before immunization, let's say about 10 to 15 years back, they were doing what we call pap smear. You see, so in the developed world, you would have an invitation to go and do a pap smear. We take a little bit of, we scrape a little bit of the cervix and look under the microscope to see whether there are aberrant cells. And if it's cancerous, you deal with it. It's easier to deal with. At that stage, it is precancerous, so you can easily kill them. Usually, we freeze it off. Okay? So it's easier to deal with it. So we can deal with cervical cancer. So that is early detection because the interval between the infection and development of cancer can be about 15 years. There's a long interval between the infection and disease manifestation. So that provides opportunity for intervention. So that is why screening is important. So in screening, you are picking, the disease is present, you see, but it has not manifested. It has not manifested, but it's already present. So you are doing tests to detect the disease before it manifests. So that is screening. Then you have other forms of screening. For prostate, for instance, sorry, my battery is dying. I have to. So breast, you can do mammography. You can do mammography to prevent or to screen for breast cancer. Blacks at blacks at more they are more at risk than whites. With our breast cancer tends to develop earlier than in whites. So our screening recommendations may vary a little. But a test, so you can have breast examination, self-examination, then clinical examination by a trained health personnel, and then mammography. These are the three ways of screening for tests. As for self-examination, everybody can do. You don't need to be a doctor. You know your breast more than anybody else. But a lot of times we ignore a lot of things. So they say for women who are postmenopausal, you choose a day, any day in the calendar month, and you decide that during this day, I will, let me use the common Ghanaian parlance, feel. May feel and there's a way of doing it. You use the flat of the palm to go around. Right. So, but breast self-examination is okay. It's okay, but we have something called sensitivity. The ability to pick a lesion in the breast is not as good as mammography. You see, so the recommendation for mammography for us is 40 years for us. Elsewhere, it's getting to 50, but for us, it's 40 years. But if you have certain risk factors, family history, then you start earlier. You start mammography earlier. And this will continue. Now, the recommendation is that even up to 75 and beyond. You see, I've seen 80-year-olds develop breast cancer. So it means that, yes, madam. So self-examination is monthly. So when you choose a day in the calendar month, it should be regular. This if it's 5th of every month, every 5th, and so on. Okay. Then the clinical examination is once a year. Clinical examination is once a year. Then the mammography. So you begin at 40. Depending upon your risk profile, we design something for you. Initially, annually, then after doing it several times, you do it every 2 years. Screening is not perfect. Screening is not perfect. You may miss it. Okay. And the other thing too is that for very aggressive cancers, you may do a mammogram, let's say this year, August. So you are scheduled to have the mammogram next year, August. We have cases where the cancers develop in between. So it is not good for very aggressive disease. That is why you must combine all the modalities, the self-examination, the annual examination, and the mammography. Right. We have other cancers like prostate cancer, recommendation for screening. You see, so as I said, the definition of screening is test performed in healthy individuals to detect the presence of disease. So the test is being performed in healthy individuals. I don't like it when people come on air and they will say, oh, cancer, symptoms of cancer, full urination, blood, and so they are symptoms, it's correct. But if you would wait to develop those symptoms before you seek medical attention, it means that you are inching towards a time that nothing can be done about it. So the emphasis is on a screening, doing the test at a time that you don't have any symptoms. That is what you refer to as screening. Ghana, you see, everybody is a professional. So you have all kinds of people. I'll borrow my father's language, who know next to nothing about the subject, coming on air and saying all kinds of things. And most of us believe anything that we hear on air. Once we hear something on air, we think it's true. That is not true. Okay. So the emphasis is on test on asymptomatic individuals, those without symptoms. Right? So that will apply to all forms of screening. Okay, so we've spoken about it. So there's self-examination, and it's teaching us how it is done, lying down, sitting down, first looking at, you know the appearance of your breast. Everybody knows the appearance of any part of their body. So when there's a change, you can detect it, okay? And then you have symptoms like bleeding from the nipple, dimpling, skin changes, and so on. But those are late presentation. We don't want to get there. So this is how a mammogram looks like. So you can see the density, okay? A very hyperdensity. Why it is. Mammogram is basically an X-ray. Okay? Most of us are familiar with X-ray. but we usually will do x-rays of bones. So let's take it that mammogram is x-ray of the breast. So when there's a density such as this one, it can pick it up. And then what we do for pregnant women too, uh, we call it a video. That one too can be done on the breast, ultrasound, to pick up breast cancer. So I've discouraged this, but I have to mention it. So nipple changes, bloody discharge from the nipple, lump in the breast, change in the color, pitting of the skin, and then a little bit of pain. Pain is not too common. Pain is not too common. It can be asymptomatic for a very long time. So these are the symptoms, but my emphasis is on the screening. So what do we do? When the diagnosis is made, you have two options. No, the one before this one. Yes. So you can see that the breast on your right side has been removed. Okay. In the past, that was the standard management. Breast has been removed. Okay. That is not the standard management now. Now, those days that I used to do locums elsewhere, you will find that about 80% of the breast cancer that you see, we preserve the breast. And here I try to promote it a lot because the reason why people come late to our hospitals, it's not because they cannot detect their breast cancer. It's because of fear of the treatment, fear of losing their body part, and the effect on their marriages. Whether we like it or not, it is a fact. I have seen people whose marriages have gone down the drain because they had a mastectomy. And so the wives know, because the wives know, they will not do it. They will not do the mastectomy. They won't remove the breast. So they live with it until such a time that it's unbearable. Then they present. At the time that they present, it's already gone elsewhere. And if we are managing you, we are managing the symptoms. We are not curing. Okay. So the good thing is that the good thing is that if you come early, there's breast conservation. You just remove the lump. That's it. And then you must do whole breast radiation. After removing the breast, you must do whole breast radiation before the results come equivalent to removing the whole breast. When I finished training, I returned back to the country. We have meetings. So some of the surgeons, my teacher, one of my teachers, telling them that, look, contemporary times, after the mastectomy, you must add radiation. And they were arguing. Okay? I said that, it's not like the Bible story that you resect the thing, you go and show yourself to the high priest. No. I shouldn't say lucky, but the next patient that arrived, even though the breast had been removed, the cancer had come back on the chest wall. It's very common. These days, it's not too common, but because we have radiotherapy, and so we do it. So just removing the lump or removing the breast does not absolve you of future recurrence. That is why you must talk to the system that has been created by a health service for management. Okay. So there are times that you remove the breast, you have to do chemotherapy. The reason for chemotherapy is that a cancer disseminates. Okay. At the time of diagnosis, we do imaging, detect whether there are some cells that have lodged somewhere. So we image the lung, we image so on. Sometimes you find that there's nothing in it. But the fact that there's nothing in it, sometimes it's because the cells have not aggregated. It is only when they aggregate that the X-rays will pick it. But if it's tiny, tiny cells in the organ itself or in the bloodstream, it will not be seen. So to take care of that, that is why you give chemotherapy. And I know that the press is full of bad things about chemotherapy, and nobody's disputing it. Nobody's disputing it. Why is it that, look, the US and UK, so almost every corner there's a cancer center? If it was not beneficial, why would they have cancer? The density of radiation therapy machines in US is about 1,500 or so. It's very dense versus us. We have about only 3 in the whole country. No, they know the usefulness. You see, but we are dominated by misinformation, and a lot of times we believe them. I mean, the side effects may be there, but this is just showing that if you do radiation and other treatments with the surgery, that is when you have superior outcome. So, yes. Yes, madam.
I understand that the cancer cells, they detest nights and fresh air.
Fresh
air.
Air.
Oxygen.
Oh, okay.
So as soon as you open it for the biopsy or you touch it goes berserk. And I understand also that the surgeons know once they cut, they can tell even without us there. Why is it that we wait so long after the biopsy to get our results? By that time, the cancer has already started spreading. And it's not our fault. A lot of people die because of that. Once they do the biopsy, it's painful to get the wound healed. Then they wait for so long for them to be scheduled for the surgery before they start all that you are talking about. By that time, the woman is already dead. So please, I think you people will also have to pick up and help the public. Thank you.
So that's a very good question. So your preliminary statement is true. We call it repopulation. It's about self-preservation. And cancer too wants to preserve itself. So once you touch it, in an attempt to preserve itself, it will increase the rate of division. If you have removed all of it, there will be nothing to increase the population. Okay. There was one time that I traveled from Accra to Winneba. I was driving in the company of my uncle. So I said, oh, this place is not developed at all. Then my uncle tells me that, oh, the first time they used to live in Kumasi, I said, oh, I came to Winneba for the first time in 1945. And the look then and now, big change. They say, oh, we are in a hurry too much. Well, so from his point of view, we are demanding change too quickly. I will tell you that around 1999, 1920, 2000, it took about 6 months to get a pathology report back because there were very few. In fact, when we were in 3rd year, they had to bring somebody, Professor Moazam, to teach us pathology. And he was the only one around. Then Professor Redu came, and then I think getting to the latter part of the semester, then Akusa too came. Now, if you want to get your results the following day, you get it. Things have improved so much. Now you have pathology labs springing all over the place. You see, there are changes that they take time to develop. We don't make noise about good things. The establishment of what is at RAGE, the Ghana College of Physicians and Surgeons, provided a platform for us to train people well. Now we have several pathologists. So the turnaround time has reduced from about 6 months to 1 week. Most of our results come back after 1 week now. So that aspect has been dealt with. Now, the other one is scheduling theater time. Theater time is a big problem. Big problem. So the doctors are aware. But if the theaters are not available, what will you do? You see, to the extent that we try to solve that problem, there are patients who don't need chemotherapy. But we are just buying time. So we say, start chemotherapy. So we book you now. Now the waiting list is 3 months. So you join the list. Then we start the chemotherapy. We hope that by that time, then you see, at least then we are dealing with the cancer. So we are aware. We are aware. We try to do something about it. We meet every week over this. So there are cases that even when there's no theater space, we have to do it. So we try, we prioritize. It can be done. In fact, in private, if you want the surgery the following day, you can even get it. It's in the government system that the delays are so much. So, but you see, not everybody can afford it. Most people cannot afford being in private. Okay. So in the government setup, we try. We take the biopsy. Some will put on priority list because of the nature is. Others, some treatment just to buy time that it is done at the appointed time. I hope I have dealt with the question.
Excuse me.
Yes.
Based on what Auntie Ruth said,
yes.
Instead of the biopsy, why can't one remove the whole cancer group?
Without a biopsy, you cannot make a diagnosis of cancer. Anybody who tells you that.
If you have to wait a long time before you have it done, wouldn't it be appropriate to remove it and then, then that's done?
If later we remove it and we find that it's not cancer, then you have lost a breast when you didn't have the disease. You can take me to court. See, these days we are very mindful of people like Madame.
Talking about that,
yes.
There was one actress, one film star, who decided to get her breast removed based on the fact that her mother and her grandmother had breast cancer. So if I say to a doctor, I would like to have it removed, why should you say no, that I must wait for a biopsy? I'm doing a preventative kind of thing.
Can remove the tumor because it's done elsewhere. When the person is in theater and they remove the they do the biopsy very fast and they come back, it's positive. They will remove the tumor. So that is once. You don't have to book theater again. Can't we do that?
Oh, I'll answer the question by what Auntie Rose is saying is that elsewhere, at one theater session, they remove the lamp and then assess it. We call it frozen section. Sometimes we do it. Sometimes we do it. So even in that setting, it means they prove that it is cancer before they remove it. You see, because the lab service is in the vicinity of theater. So the moment you biopsy it, straight away it goes to the pathologist, pathologist looks at it and sees that, oh, it's cancer. We call it frozen sections. Then there and then the diagnosis has been made. So then you can take care of it. So whatever it is, we need a diagnosis. We need a pathological diagnosis. But you see, for now, Ghana, our circumstance, pathology is not a problem. Now our problem is the theater time. That is the problem. And it is getting better, but it is too slow. Not only the theaters, but anesthetists and so on. It's complicated. We don't have enough anesthetists. We haven't solved that problem. We've solved the problem with pathologists. We have enough surgeons. The problem now is anesthetists. It's a big problem. Most doctors are not interested in anesthesia. So not many people are going into it. But you need an anesthetist to do surgery. There was a hand up here.
One of the challenges why women don't come for the biopsy is that they are afraid of the consequences. I think that the other issue is to do with the financials because it's not cheap. So is there any indication of like the cost for if you are going to do it in a public hospital as against the private hospital so that people can make a decision based on our ability to pay? Thank you.
I was also going to talk about cost. We are HR people, so that is a concern. And I'll add that is there a reason why, knowing the queue is long for the theater to theater booking for people who need it, the surgery, why are we not promoting insurance, adding breast cancer surgeries to the national insurance provisions that we have? Sometimes I feel that maybe because the women are many and decision makers are not too many ladies up there, some of the things that can be done for women take much longer. But I was also going to find out what the cost is approximately. I think it's good for us to know at the public hospital and at the private hospital, what are the range? I mean, it can be a range, not a specific. But why are the doctors not encouraging whether organizations or corporate NGOs to help set up some type of insurance system that will help women to benefit, especially knowing that they have to wait for so long? Thank you.
Yeah, breast cancer management is on health insurance. Yes, it is. Breast cancer, it is rather prostate cancer that is not on health insurance. So, in fact, I hate gender arguments. I hate gender arguments because we have wives, we have mothers, we have daughters. Whatever will happen to the girls will affect us. So let's attack the real subject. On health insurance. You see, as I'm a practitioner, I practice medicine, all right, but I do management too. It's complex. Now. So that you budgeted for. You know what we are experiencing now. Budgeted 2 cities. Now, in reality, it's 10 cities. What are you going to do? The premium that you pay is nowhere near the cost of the thing. So co-payment is a reality. They say we shouldn't say it. So I have to not say. But the reality is that it cannot cover it. It's our poverty. That's the bottom line. It's our poverty. Doctors, we try. We try to do what we can. Believe me, every doctor tries to assist their patients. It's just that sometimes we are limited by resources. The health insurance is not useless. You see, there's a drug that about 5 years ago cost 100,000 a year. Now it is free on the health insurance. Yes, accepting is free. And people get it. So, everybody who is eligible gets it. Indeed, now, in today's terms, it will be about 200,000 and more. But they get it for free on health insurance. You see, so there are bottlenecks in the problem. But now, unless there are some drugs that are too expensive, if we say we put it on the health insurance, it will collapse. Those drugs, you see, the one that I'm saying is very expensive. The only reason why they put it on it is that if you take all breast cancers, only 20% are eligible. Suppose it was 100%, I don't think they could have afforded it. You see, so the system is improving, just that it's not perfect. The problem is not the pathology. Now it is theater time and anesthetist. I think I've spoken a lot about cervical cancer. So for our purpose, let me speak about cervical cancer. It's important to me. So, considering the audience, when your period ceases in menopause, you should not bleed. Any bleeding that occurs after menopause must be investigated. It may not be cancer, but most of the time it is not cancer. But if bleeding occurs, you must see your GP or your gynecologist, because postmenopausal bleeding can be cancer. So we have to take that very serious. It could be endometrial cancer of the womb, or it can be cervical cancer. It can be other cancers. If you see the gynecologist, they will attend to you. Then, premenopausal intermenstrual bleeding. If you have a regular cycle and you bleed between cycles, you might take it serious. Or intercourse is painful, or there's bleeding after intercourse. Those are signs of cervical cancer. So you have not screened and developed those symptoms. It must be dealt with. Okay. So I've spoken about pap smear and the vaccination already. The prostate cancer, you see, when you speak about prostate, change up to the diagram, the next. Yes. Prostate cancer, most breast, we can relate to it because we can see it. Prostate, we can't see it. What is the vernacular for prostate cancer? Prostate. You see. So it is behind the root of the penis. The root of the penis, the prostate is behind it. But the use. Every structure in the body has a use. What it gives out is responsible for liquefaction of semen. See that semen is thick. The way it is thick, the spermatozoa cannot move. So, but it has to be thick so that it can be concentrated and released. But once it comes out, what is in it? The sperm should be free, so it must be rendered watery. So the prostate secretes a chemical that can make it loose. So it's important. But it means that if you don't have a prostate, it's still compatible with life. If you don't have a prostate, it is still compatible with life. So then, why don't we go about removing? I will line everybody up and you see, The surgery for prostate cancer is a big surgery. It's big surgery, and the complication rate is also quite high. Well, these days, it's not as high as previously, but it is not zero. There is the risk, the biggest fear is the risk of incontinence of urine. You see, because in that region, I mean, in women as well, we have what we call the pelvic floor. You see, the contents of the pelvis, it sits on a demarcation, something that supports it. So once that support becomes weak, in women, people can have prolapse and so on. The same thing in men, the prostate is sitting on that support. And that support is important for, you see, the bladder has, we call them sphincters, like valves, that prevent the urine from coming out when you are not ready. So it weakens that support when you do prostate surgery. Okay, that is one. And the other side effect is erectile dysfunction, that you lose potency. And there's no man in the world who want to lose the potency. You have to be a man to understand. The men don't understand. Right, so because of the problems that can be associated with the removal of the prostate, we don't recommend that. Okay. That reminds me of the total mastectomy. Yes, Angela Jolie or something like that. That was the name of the actress. You see, there's a gene. There's a gene that some people carry. About 5 to 10% of all breast cancer, there's a gene. And so that gene, if you have it, puts you at risk of developing breast cancer. So some have resorted to removing their breast, whether they have that. In fact, that no diagnosis has been made. That one is a personal matter. And I'll tell you that 90% of women don't like it. So we are about ending. I think so when you do a PSA, it's the test we do for screening. Like breast cancer, we need tissue to make a diagnosis. Without tissue, you can't diagnose any cancer. So there's a probe. Next. Yeah. So a probe that you put into the backside and take a piece of it and send it to the lab. But before that, the recommendations for screening. The slide before this one. Yeah, so in blacks, the recommendation is 45 years to start screening. And that can continue to up to about, in some circumstances, they say 65, others, they say 70. But you need, when the PSA is elevated, to prove that it's cancer, you need a biopsy before you do anything else. Next. So again, screening is test performed. Okay.
Is it true that most of these cancers are genetical?
So most cancers are not. Only about 5 to 10%. Okay, let's put that 10. About 10% of cancers are linked to your something that you've inherited. So 90% of the time, cancer is sporadic. Just happens. 90% of the time. That is why you shouldn't say that, oh, my father didn't have any cancer, neither did my mother have cancer, so I'm absolved. No. 90% of the time, there's no relationship. So screening is test performed in asymptomatic individual. So for the men, prostate cancer, you want to do the PSA when there are no symptoms. If you don't take advantage of that, then you start having, I want to explain something. There's a difference between what we call BPH, benign prostatic hypertrophy, and cancer. The prostate gland can be enlarged. So when it's enlarged and you're having to get up to urinate several times, because let's say for a glass, if you are emptying, you are not emptying well. Let's say you empty about quarter, then it gets full in no time, versus when you are emptying up everything. That is why people will get up several times to urinate. Sometimes when you feel like urinating, you have to rush and so on. Those ones, it can occur in cancer, but 80% of the time, it is benign. It is the prostate cancer that is enlarged. You see, enlargement is synonymous to cancer. That's why we insist that we need a tissue diagnosis to make a diagnosis of cancer. Right? And so we don't compromise on that. We need the tissue. Unless, of course, all cancers, you come and we do imaging and we find lesions in the lung, the liver, and elsewhere. No, we don't need tissue diagnosis. It's so obvious. See, you can have PSA of 2,000. Normal is up to 4. PSA of 2,000, we have had instances when it is just urinary tract infection. Put the person on antibiotics, it goes back to normal. Yes, madam.
I've heard that pancreatic cancer is on the rise. Is there any therapy or something to do to prevent it happening?
Unfortunately, pancreatic cancer is one of the cancers that the risk factors are not well, I should say, established. Because of that, I don't know whether I put, yes, pancreas. You see, 35, it's only in 35%. I don't know whether you can, oh, sorry, I keep on forgetting. Those round circles, yes. It's only 35% of the time that it is related to something that you can deal with. But this prevention, sometimes in practical, sometimes it's nebulous. Because you see, you control your weight. Okay. You don't smoke. You don't drink. You eat fruits. Those are the things that they say will help you. But that does not, because you do all that. You see. So that's the problem. So management of prostate cancer, there are 3. If it's very early and it's not aggressive, we just observe, particularly when you are a bit old. But when you think that you have a life expectancy of more than 10 years, then we will actively treat you. And it's curable. The modes of treatment, it can be what you call external beam radiation. It's just you are using X-rays. You are using X-rays, but it's focused X-rays that you target on the prostate gland. So that is one means of treatment. Or you remove the prostate cancer, or we put radioactive material in the substance of the prostate, and you have very good results. Outcomes are almost the same with all of them, but the side effect profile is better with what we call brachytherapy. Putting seeds in the prostate is better relative to surgery. Yes, sir.
I would like to ask a question about the biopsy. I have never seen any test that is as undignifying as the biopsy. And I'm wondering whether there's been any development in that area.
Yes, I agree with you. But unfortunately, there's been development in terms of accuracy. In the past, it was blind, right? The surgeon will go in, palpate, and then take blind biopsies. And then we move to ultrasound guidance. You see, ultrasound, this one, for the ultrasound is attached to the probe. So you can see exactly where the needle is going. Now we do MRIs. Okay, the special types of MRI that you can do even prior to the biopsy that can map out the prostate gland so that you know exactly where you are going to. You see, but as for the procedure itself, as for that one, there's nothing you can do but to position you and do it. Yes. See, they are trying to develop ways of developing cancer, diagnosing cancer without a biopsy, but it hasn't reached prime time. Yes.
What are the risk factors for prostate cancer? That's number one. Number two, if it's so very common among males, why has it not been screened for in this country?
So, again, if you show those cycles, that's not something that we can prevent. Okay. One. So we need to screen. We try to screen, but it's all cost. About 3 months ago, I was part of a panel that the National Health Insurance has formed. So we are working towards it. We are working towards putting prostate cancer on the health insurance. It's all about ability to pay for it. I've seen some where they have put everything on health insurance and it collapsed. So you do actuarial studies, two very critical actuarial studies to determine the numbers you'll be dealing with and the cost of treatment. So the panel, I'm part of it, there's a surgeon, and then the actuaries are also the public health physicians. We are working towards putting, not too sure, it's after, we've given them the figures, but it's when they do their mapping, then the actuaries can tell us whether we can put it on the health insurance. Believe me, the system tries to work towards perfection, but we are constrained by resources. Yes, please go ahead.
You just mentioned brachytherapy, and can you enlighten us a little bit more? And what are the after effects if you have that line of surgery for your prostate?
So it's a complicated procedure, but the long and short of it is that under imaging guidance, we track tiny pellets into the prostate, and they are radioactive material, so they give off the radiation. Okay. So because they give off the radiation, you see the urethra, the pipe that carries the urine, is in the substance of the prostate. It receives some of the radiation. So initially you have a burning sensation, but that lasts. Usually it doesn't require any medication. Most people don't require any medication for it. It's just that the urine is a bit hot. And in between urination, you don't feel anything. That's the major side effect. All prostate cancer treatment, whether it's external radiation or the brachytherapy, which is inside, or surgery, they have the common side effects of erectile dysfunction and incontinence of urine. But the rates are lowest, current data, the rates are lowest for brachytherapy. Yeah. So that's, and you see, no cancer treatment is foolproof. So we construct, we call it survival curve. So we can estimate probability of recurrence based on the characteristics. But to tell you that you have been cured, we doctors, we don't usually see that. We can tell you the probability. And I have several patients See, Ghana, because of perception of stigma, people don't like to come out to say it. But I have several patients that I treated more than 15 years ago, and are still alive. Several. Breast, cervical cancer, some of them you know. And some of them are political figures and so on, yes. But elsewhere, they will come out. When Barbara Bush had breast cancer, they used it to help the system. But ours is not like that. So sometimes it appears that cancer is uniformly fatal. No, it's not at all. And cancer is one disease. It's about over 1,000 diseases. The behavior, every cancer is behavior. Even within one diagnosis of prostate cancer, not all prostate cancer is the same. So each of them has, so we prognosticate based on the characteristics. I think we are about finishing. You took the wind out of my sail. This slide. Next. Oh, you are going back. Yeah. I'm done. So we've discussed this already. Financial barriers, logistical barriers, and psychosocial barriers. Let me end by mentioning complementary and alternative medicine. There are all kinds of. I remember when I was growing up, one of my uncles was traveling from Accra to Winneba, but somebody was selling something on the bus. This is an educated man. My uncle was Kene Pakayani. Those of you who remember the cool days, he was commissioner for information. They were trained in Sandhurst. Ubasanjo and the rest were his classmates, Champo and all this. He's very educated. He bought this herbal medicine, he came home, he took it, and then the diarrhea that he had, you see, so it's not that doctors don't like it. There is no evidence of its efficacy. And then the side effect profile may be the same as what we are giving you. So then together, there's a multiplier effect. You have terrible side effect. You see, so we don't advise using herbal preparations. And again, you see, it prevents people from having a cousin, right? I have a cousin, very talented. Some of you know him. Via Sufi. Music. Very few people could play music more than Via Sufi. He had like a stroke. You see, when you take the herbal preparations, it gives you a false impression. It may be good, but the active ingredients in it have not been extracted. It's coming with all kinds of things, which may be detrimental. I think I'll end here. Thanks.
Dr. Yani, your topic seems to be one that needed 4 hours because there are so many questions. But you to me, you want to ask me a question? Hey. The dance teacher's time is past. He has a class, and he really can probably just do 5 minutes.
My question is, can we look at the issue of fibroids the next time?
So please, can you help me thank Dr. Yani with a big clap? Dr. Yani, thank you so much for your time. It was a struggle to get him here, and I'm sure we've understood cancers a bit, much more than we did before we came here this morning. Thank you, Doctor. So I'll ask you to kindly get up, move away a little bit from your chairs so we can quickly push it back before the dance teacher disappears. He has a class at 12:30 and it's 12:20.